Hello everyone, happy evening, a very good evening. I hope and I believe all of you are doing well. A quick note whether the audio visual is all good so that we can kickstart with this session on the 100 most important one-liners in radiology for your upcoming exam. So let me tell you that these one-liners are important for the upcoming INI-CET exam. They are also important for all the exams, be it NEET PG or be it FMGE. So a quick note whether I'm audible and visible. Okay, that's great. Amazing. So, this is like one of those sessions in radiology where you might not see a lot of images because this is like the binge revision of whatever science, important points in radiology you've already learned. So, we will quickly skim through all these important points. I hope all of you are good with that. I have also shared the PDF on the Telegram group. On my Telegram group. So in case you want to make the notes as you are watching the video, you can do that as well. Okay. So yes, thank you so much, Sam, for the compliment. All right. So let's start with this, the 100 one-liners in radiology. The first important thing is we'll start with the investigation of choice or the most sensitive investigation. Tell me what is the most sensitive investigation for air, for fluid, for calcification, and for soft tissue. So remember that for air, the most sensitive investigation for air is CT scan. So for any air containing pathology, be it pneumothorax and pneumoperitoneum, it is CT which is the most sensitive, not ultrasound, not MRI. For fluid, it is ultrasound. So remember when I write fluid, the U tells me that it is ultrasound, which is basically for fluid. For calcification, remember C for C. For calcification, it is CT scan, and for soft tissues, it is MRI. MRI is the investigation which has a very high soft tissue resolution. And if to the list I add on the bones as well, so remember that for bone cortex, okay, what is it for the bone cortex? For the bone cortex, C for C, it is CT scan. For the bone marrow, M for M, it is MRI. Okay, so for the bone marrow pathologies, it is MRI, and for the bone cortex pathologies, it is CT. Right. I hope the audio is good. Aisha is saying the audio is low. Someone said the audio is very good. Please let me know on that front as well. Right. So that was the first slide there, understanding the most sensitive investigation for the various pathologies. Now going on to the next one, very, very important, that is you have a patient with low backache, with morning stiffness, right? And the red eye dagger sign is positive, bamboo spine is positive. So what is the dagger sign? This sign that you see that in the midline, there is this white line which suggests the ossification of the interspinous ligament. That is the dagger sign. Okay, that is the dagger sign there. And the fusion of the vertebra by the syndesmophytes, that is the bamboo spine. Right, absolutely right. So the diagnosis there is ankylosing spondylitis. Why there is low backache? Because ankylosing spondylitis starts with sacroiliitis. Why is there morning stiffness? Because it is inflammatory arthritis. So the inflammation has morning stiffness. Why is there red eye? Because the uveitis is a very common extra-articular manifestation with ankylosing spondylitis. Right. So remember that this is AS. We need to test for HLA-B27 is what is going to be positive here. And in the treatment, basically, we will give painkillers. NSAIDs is what we will give. Okay, NSAIDs is what we will give. Right. So going on to the next one, what is the nuclear scan for parathyroid adenoma? What is the nuclear scan for parathyroid adenoma? This is a very, very important question asked in almost all the exams. That is the SISTA-MEB scan. Okay, that is the SISTA-MEB scan. Also, sometimes it will always also be mentioned as MEB scan. Okay, the SISTA-MEB or the MEB scan. And what is the history that is given with hyperparathyroidism? What are the clinical features that is given? Stones, bones, moans, and groans. So there is history of the renal stones. There is history of bone pains, there is abdominal pain, and there are psychiatric features. So when you have this in the question, think of hyperparathyroidism. SISTA-MEB scan is what we will do for the same. Next one. Tell me the tumors which are FDG PET negative tumors. They are tumors, but still they are negative on FDG PET. What are those tumors? Which are the FDG PET negative tumors? Yes, tell me at least two tumors. So that means basically we are getting the false and negative results. Okay, basically we are getting the false negative results there. Very good. Absolutely right. The previous AIMS exam question, it is typical carcinoid, not the atypical carcinoid. The typical carcinoid is the one which is a well differentiated carcinoid. A tumor which is low grade, which is well differentiated. Basically, this is similar to the normal cells, and that is why they do not take up a lot of glucose. Again, another example, which tumor is FDG PET negative? Which lung tumor is FDG PET negative? Which lung tumor is FDG PET negative? So remember the low grade adenocarcinoma, which is back bronchoalveolar carcinoma. Okay, that is bronchoalveolar carcinoma, which is the FDG PET negative. It's your low grade adenocarcinoma. Okay. And also remember that where do you get the false positive PET results? In infection and in inflammation, you might also get PET positive. That is why the gold standard investigation is biopsy to confirm whether it's a tumor or it's not a tumor. And where do you get the physiological increased uptake in PET? That is your supraclavicular regions. The brown adipose tissue there in the supraclavicular regions, that is the physiological uptake in the PET. Okay, that's the physiological uptake in PET. Next one, tell me which is a nuclear scan for bones? Yes, lipidic pattern of growth is seen with bronchoalveolar carcinoma. So it basically presents like consolidation. So if in an elderly patient you have consolidation which is not resolving with antibiotics, think of bronchoalveolar carcinoma. No, which is a nuclear scan which is done for bones. DEXA scan is basically for bone mineral density. Which is the nuclear scan? The technetium 99. What do we use along with technetium 99? It is the MDP scan. Technetium 99 MDP scan is what is basically called as the bone scan. Okay, that is basically the bone scan. And where do you get the hotspot in the bone scan? Whenever you have new bone formation, that gives the hotspot. So be it fracture, be it osteomyelitis, be it osteoblastic metastasis, you will get a hotspot. So remember that bone scan is not a very good investigation for the lytic metastasis because that will not show the hotspot. Okay, so remember it is the MDP scan, the DP, the diphosphonate scan basically. So like you have bisphosphonates drug acting on the bones, similarly this diphosphonate is for the bones. Okay. Going on to the next one, what is the sign of pneumothorax on ultrasound? What sign do you get for pneumothorax on ultrasound? So we get all the flat lines. Basically, the movement of the lung is not seen because the pneumothorax, the air above the lung, does not allow the visualization of the lung. Right? So we have the barcode sign, we have the stratosphere sign. And if I ask you what is the most specific sign, the most specific sign is the lung point sign. Okay, the most specific sign is the presence of the lung point. So look at the images here basically. To identify the barcode, look at the lower part of the image. If it is the flat lines like this, it is the barcode. If in the lower part of the image you see something which is different as compared to the above, it looks more granular, it's not flat lines, that is the seashore sign. So seashore sign is normal, barcode or stratosphere sign is pneumothorax, included in EFAST. Okay, the evaluation of pneumothorax is included in EFAST. And this is where you have the lung point sign. This transition basically from the barcode to the seashore sign, you can see both in the same. That is the lung point. Where you see the transition from one sign to the other, that is the lung point sign. Okay, so that is the most specific for pneumothorax. Right. So remember that this is the sign of pneumothorax on ultrasound. Next one, what would be that fat containing lesion in the kidney? You have a patient who has history of seizures. What do you think is the diagnosis? And what is the renal lesion, the kidney lesion? History of seizures with fat containing lesion in the kidney. What is that? Very good. The fat containing lesion is angiomyocyte. angiomyolipoma. Okay, remember it is angiomyolipoma is the fat containing lesion. And what is the diagnosis? Angiomyolipoma with seizures. Absolutely right. It has a relation with tuberous sclerosis, which is also called as epiloia. Epilepsy, low IQ, and the adenoma sebaceum. That is what we get, right? So tuberous sclerosis association with angiomyolipoma. So remember that this fat, what is the HU value of fat? Is it positive or is it negative? Remember, it has a negative HU value because it is less dense than water. Fat is oil, and oil is basically less dense than water, so it has a negative HU value, right? So remember, air and fat have negative HU value. Okay, minus 52, minus 100. So this is going to be angiomyolipoma. Tell me that this angiomyolipoma on ultrasound, how will it appear on ultrasound? Will it be hypoechoic or will it be hyperechoic? How would be the angiomyolipoma on ultrasound? Hypoechoic or hyperechoic? So remember, it's a fat containing lesion. Fat on ultrasound is hyperechoic. Remember that fat on ultrasound is hyperechoic. Fat on CT is dark, it's negative. Fat on MRI is bright. It is bright on both T1 and T2 weighted MRI. So what is bright on both T1 and T2 weighted MRI is fat. Okay. So look at this one. If you are given next time, till now INI-CET AIMS have given a lot of images of angiomyolipoma on CT. Next time if they give you an ultrasound image, so look at this. This is the hyperechoic lesion in the kidney here. Okay, so in the kidney, this is the bright lesion. So the bright is the fat containing lesion. When I see the CT scan, look at this dirty black appearance because of the negative HU value. That is fat. Okay, that is fat, which looks similar to your subcutaneous fat, right? Fat is dark on CT. So that is angiomyolipoma. Very, very important. Next one, next time they've also asked a question that there's a solid renal lesion which is enhancing and in the patient you have complaint of hematuria. Then in that case, what is the diagnosis? If it's a solid renal lesion with enhancement and there's hematuria, absolutely right, it's going to be RCC. And what classification do we use for renal cyst on CT scan? What is the classification for renal cyst on CT scan? That is the Bosniak classification. So it is the Bosniak 4 which has high chances of being malignant and we need to do nephrectomy surgery for that. Okay, so remember that RCC is what you will think of if there is hematuria and it's a solid lesion without fat. So look at this image here basically. In the kidney, we have this lesion here which is showing some enhancement, some necrotic areas. Enhancement means it is becoming white. Okay, so this is basically RCC. Okay, this is RCC. And this RCC can invade into the inferior vena cava and it can form a tumor thrombus there. So if it is forming a tumor thrombus in the IVC, then what investigation will you do for that? What is the investigation which helps us identify whether the thrombus in the IVC, it's a bland thrombus, that means without any tumor, or it's actually the tumor cells forming the thrombus? Remember, it is MRI which helps us differentiate between the two. MRI is a better investigation for that. Okay. Next one. What is the best X-ray view for pneumoperitoneum? Pneumoperitoneum is basically your hollow viscous perforation, right? The history, background history given is maybe peptic ulcer ka history, and there is now acute pain, there is rigidity, guarding is what is present. So the best X-ray view is chest X-ray erect. Okay, the best X-ray view is what we are talking about. It is the chest X-ray erect because it helps us identify this air under diaphragm, the free air under diaphragm. So it is quick and it helps us identify that, right? So pneumoperitoneum, another important question, you have this free air under diaphragm that is present. What will be the management? It's going to be give IV fluids, stabilize the patient and take the patient for surgery. IV fluids and laparotomy is what needs to be done, right? So next one, if not chest X-ray erect for pneumoperitoneum, then which X-ray view will you do? If the patient is in a bad condition, not able to stand erect, then which X-ray view would you do? Absolutely right. It is left lateral decubitus. It's going to be left lateral decubitus with the horizontal beam of X-ray. Okay, remember it's going to be left lateral decubitus with a horizontal beam of X-ray. Absolutely right. So this is the image which is showing the right side is up, the left side is down. So in the left lateral decubitus, the left side will be down. So the air will go to the right side, and this is where you are seeing the black air going to the right side. So this is the left lateral decubitus. So in a neonate who cannot stand erect, pneumoperitoneum, it's common, a complication with necrotizing enterocolitis where you have the bell staging. In that case, you can do left lateral decubitus with a horizontal beam. Okay. Next one. If you see a coin which is circular on AP view, then the coin is in esophagus or the coin is in trachea. So you have a AP view of the X-ray and you are seeing a coin which is circular on the AP view. Then the coin is in esophagus or the trachea? Absolutely right. The coin is in the esophagus. So remember it as esophagus when I write. The O tells me that it's a circular coin in the AP view. Trachea when I write. Trachea, the T, the vertical line of the T tells me that it's a slit like in the AP view. Okay, so the trachea will be the slit like and the esophagus will be circular. Opposite in the lateral view, the circle will become a slit, the slit will become a circle. Okay, so remember that coin circular on AP view is the coin in esophagus. If it is asymptomatic patient, you need to just wait and watch. Right, if it is a symptomatic patient, then you need to remove the coin. And instead of the coin, if they give you the button battery, a child has ingested button battery, what will you do next? You will not wait and watch there. It has to be removed, right? It has to be removed. The battery, we cannot wait and watch with the battery. Okay, it has to be removed. So remember that these are the important points for your coin and the button battery. So look at this one, the AP view, this is the circular coin. So this is esophagus and this is slit-like on the lateral. So this is the esophagus coin. Okay, this is the esophagus coin. Next one, tell me the substances which are hyperdense on non-contrast CT. Two things which are hyperdense on non-contrast CT. Yes. Very good. Absolutely right, Vandana. That is acute hemorrhage. Remember, it is acute hemorrhage and calcification, which is hyperdense. Hyper anywhere in radiology basically means white. So white on non-contrast CT is acute hemorrhage and calcification. Remember, not the chronic hemorrhage. Because acute hemorrhage, because of the fresh RBCs, it is dense, increased density, hyperdense. Chronic hemorrhage, because of the RBC lysis, the density decreases, so it becomes hypodense. Right? So how will you differentiate whether it's acute hemorrhage or it is calcification? Calcification will be as white as the bones because bones also contain calcium. The hemorrhage will be less white than the bones. So that is why for these two things, the investigation of choice is non-contrast CT. Okay, so for acute hemorrhage, it is non-contrast CT. So look at this one. This is what you are seeing here. So in the CT scan where you have the white bone, this is the CT. Look at this pathology which is hyperdense. It is white, but it is not white as bone. That is why this is acute hemorrhage. Okay, this is basically acute hemorrhage. And this one, can you tell me what calcification is this? What calcification is this one here? What is the site of calcification that we are seeing? Very good. DKH, absolutely right. So this structure here, this is the third ventricle. Behind the third ventricle, we have the pineal gland. Okay, that's the pineal gland behind the third ventricle. So this is pineal calcification, which is one of the physiological sites of calcification. Okay, this is one of the physiological sites of calcification. So this is pineal calcification. So look at how the calcification is as white as the bone. Okay, so acute hemorrhage and calcification are hyperdense on non-contrast CT. What is the most sensitive investigation for acute infarct? What is the most sensitive investigation for acute infarct? Right. The question is about what is the most sensitive. It is not asking about what is the first investigation that you would do in stroke. Right. Absolutely right. It is MRI. But which MRI? Which sequence of MRI? Very good. It is diffusion weighted imaging. DWI MRI. And what does it show on DWI MRI? It shows restricted diffusion. Okay. It shows the restricted diffusion. So remember that acute infarct is identified by restricted diffusion. Why is MRI more sensitive? Because CT in the early infarct can be normal. CT can be normal in the early infarct, but DWI MRI shows restricted diffusion, which is because of the cytotoxic edema. The cell death in infarct causes cytotoxic edema, which is picked up by DWI MRI. Okay, that's the most sensitive. If the question is what is the first investigation that you will do in stroke, then the answer will be non-contrast CT. But what is the most sensitive? The most sensitive is DWI. Okay. Next one. Which is that hemorrhage which is biconvex hemorrhage? That basically means lentiform hemorrhage. It does not cross the sutures. So also called as idly shaped hemorrhage. It is EDH. Okay, it is EDH, which is due to rupture of middle meningeal artery. Okay, which is due to rupture of middle meningeal artery. So remember, it is arterial rupture. That means it requires high force. So it is associated with significant trauma, and the fracture of the adjacent bone is generally what we see with EDH. Versus SDH, which is venous hemorrhage. It is the bridging veins which rupture. Veins can rupture with trivial trauma also. So it can have chronic history as well. It can be seen in alcoholics, right? Battered baby syndrome. We see the SDH. Okay, right. And S for S, remember it is sickle shape. The SDH is sickle shape, concave or convex. The EDH is biconvex shape. Okay, so this is how the EDH is. It is idly shape or biconvex shape, and it does not cross the sutures. It can cross the midline, but it cannot cross the sutures. Next one. What is that sign in chest x-ray or CT chest which helps us differentiate whether the parenchymal, the pathology is parenchymal arising from the lung parenchyma, or is it the extra parenchymal pathology? What sign in the chest x-ray or the CT chest helps us differentiate a parenchymal from the extra parenchymal pathology? Very good. Absolutely right, Dr. Shelby. Absolutely right. That is the air bronchogram sign. Okay, that is the air bronchogram sign. See, air bronchogram sign. What is the air bronchogram sign? So look at this image. So in the background of the white lung, so there is this white lung, and through the white lung, you see the black bronchi which are going. Normally also we have the black bronchi. So normal, what is happening? The lung is air containing, it is black. The bronchi are also air containing, it is black. So both are black. So they merge together and we are not able to differentiate. What happens with consolidation, a parenchymal pathology? The lung becomes white, the bronchi are still black. So you get a good contrast, that is the white and black contrast, right? So basically that's the air bronchogram sign. In the background of the white lung, we see the black bronchi going. That is the air bronchogram sign. So this will be seen in parenchymal pathology only, not in extra parenchymal pathology. Like pleural effusion will not show the air bronchogram sign because you don't have the bronchi going outside the lung. The pleural effusion is outside. You don't have the bronchi outside the lung, right? So remember that air bronchogram sign when present tells you that it's a parenchymal pathology. So it will not be seen. Okay, so it will not be seen in pleural effusion or in mediastinal mass. Previously asked question. So any extra parenchymal pathology will not show the air bronchogram sign. It is present in parenchymal pathologies with consolidation, any cause of consolidation, be it pneumonia, be it pulmonary edema, be it hyaline membrane disease where you get the whiteout lungs, be it pulmonary hemorrhage. So any cause of consolidation will give the air bronchogram sign. Okay. So this is air bronchogram. Next one. Tell me what is the normal arterial and venous waveform on Doppler? Is it monophasic? Is it biphasic? Is it triphasic? What is the normal arterial waveform and what is the normal venous waveform? Very good. The normal arteries, if I'm talking about the limb arteries here, they give the triphasic waveform on the normal Doppler because of the high resistance. Right. So remember that the limb arteries are the high resistance arteries and they give a triphasic waveform. Veins give a monophasic waveform but with respiratory phasicity which is present. Right. The veins show respiratory phasicity. If the respiratory phasicity is absent, there is loss of respiratory phasicity. That means it is suggestive of DVT. So monophasic without the respiratory phasicity is suggestive of the block. The respiration is not getting transmitted to the vein. Okay. And whenever there is DVT, right, bedridden patient, cough, pain, Homan sign positive, DVT, what do we do first is ultrasound. What ultrasound? Compression ultrasound. Why compression ultrasound? Because if this is the vein with the thrombus within, right, and this is the normal vein. So when you compress the normal vein, it gets compressed with the pressure. But if there is thrombus in the vein, it does not get compressed. So remember that a thrombosed vein is non-compressible. A normal vein is compressible. Okay, a normal vein is compressible. So that is the other important finding that can be mentioned in the question. So compressible vein, normal, non-compressible vein is a thrombosed vein. Similarly, in which organ in the abdomen do we use this graded compression ultrasound? For which organ do we use the graded compression ultrasound? Appendicitis. Okay, that is for appendicitis. So if the appendix is inflamed, it is filled with fluid, it is blocked. If you compress it, it will not be compressible. So if it is inflamed, it will be non-compressible. Okay. So look at this waveform here. Basically, this is the triphasic waveform. This is the triphasic waveform that we are seeing here. So that is the arterica waveform. And this one is the respiratory phasicity. The flow is only on one direction, but there is respiratory phasicity in the vein. And look at the color, the red color, the blue color. The color indicates the direction of the blood flow. Okay, the color indicates the direction of the blood flow. Okay, so this is about Doppler. Going on to the next one, where do you see Rigler's sign and where do you see Rigler's triad? Rigler's sign and Rigler's triad, where do you see that? Rigler's sign, very good, is seen in pneumoperitoneum, absolutely right. And Rigler's triad is seen in gallstone ileus. Okay, Rigler's triad is seen in gallstone ileus. Right. So look at this one. This image is showing the Rigler's triad where you have the ectopic gallstone, you have the dilated small bowel loops. That is the ectopic gallstone leads to the small bowel obstruction and you have the air in the biliary tree. That means that there is pneumobilia. So these are the components of Rigler's triad. Ectopic gallstone, small bowel obstruction and pneumobilia, not hemobilia. And what is the Rigler sign here? When you see the bowel wall very clear on the abdominal x-ray, because of the air inside, because of the air outside. The air outside because of the pneumoperitoneum. So the air outside, the air inside gives a very distinct appearance to the bowel wall. That is what is called as Rigler sign, which is seen in pneumoperitoneum. Okay, that is what is seen in pneumoperitoneum. Okay, so remember the Rigler's triad versus the Rigler sign. Next one, in which investigations there are no ionizing radiation? Which two investigations there are no ionizing radiation? It is ultrasound and MRI. If it is ultrasound, it is Doppler also, because Doppler is nothing but ultrasound. It is fast also, because fast is nothing but sonography. If it is MRI, it is MRCP also, because it is nothing but MRI. So any form of ultrasound, any form of MRI does not have radiation exposure. X-rays are used in CT scan, X-rays are used in radiographs, so they have radiation exposure. There is radiation exposure in ERCP also, because this is basically a dye study. A dye study basically means a contrast X-ray study. So ERCP, HSG, IVP, MCU, all of these are contrast X-ray studies and they have radiation exposure. Okay. Next one, coming to some empty signs, the empty delta sign, the empty Sella sign, and the empty Theta sign. Where do you see the empty delta sign? So in the CT brain, this is where you have the empty delta, the triangle which is empty in the posterior part. It is the superior sagittal sinus thrombosis. Absolutely right, DKH. Dr. Shelby, we are yet to come to the arachnoiditis part. This is the empty delta. Delta is the superior sagittal sinus, which looks like a triangle. Look at this image here. So in the posterior part, this is the delta that you have, which is empty because it is thrombosed. It does not allow the contrast to go there, right? And what is this part indicating? Because of the venous sinus thrombosis, there is generally hemorrhagic infarct. So remember that a venous infarct is generally a hemorrhagic infarct because the venous thrombosis leads to stagnation of the blood and it is hemorrhagic infarct. Okay. So remember that this is the empty delta sign in superior sagittal sinus thrombosis on contrast enhanced CT, not on non-contrast CT. Mount Fuji sign यहाँ पे नहीं है. Mount Fuji sign is in pneumocephalus. Right, where you have ऐसा वाला, you will see the black air accumulating here. That is pneumocephalus. That's the Mount Fuji sign. Where do you have the empty Sella sign? Where do you have the empty Sella sign? Empty delta, superior sagittal sinus thrombosis. Empty Sella is where the Sella, you don't see the pituitary, all you see in the Sella is the CSF, right? Where is it seen? With causes of raised ICT, right? Raised ICT causes raised intracranial tension. So the raised ICT, imagine that it is rupturing through the dorsum Sella and all the CSF is going into the Sella. So we don't see the pituitary gland, all we see is the CSF in the Sella. So that is what we have with raised ICT. Pseudotumor cerebri is one of the causes, right? Pseudotumor cerebri, what is the clinical history that you generally have? It's an obese female with chronic headache, right? So that is generally the background history. Think of pseudotumor cerebri. Okay. Next one, empty theca sign. What is theca? The thecal sac, the spinal cord wala, the phylum terminal wala, the thecal sac, the CSF sac. This has been asked in the AIMS exam previously. Empty theca sign is seen in arachnoiditis. Okay, now this is arachnoiditis. So look at this one. This is the MRI where you have this thecal sac just showing the CSF. You are not seeing the nerve roots here. Normally, you should have seen the nerve roots here. So what happens is when there is arachnoiditis, it causes the clumping of the nerve roots in the arachnoid. So you don't see any nerve roots there. So remember that it is arachnoiditis which shows the empty theca. All the nerve roots are clumped because of the inflammation of the arachnoid. That is the empty theca or the empty thecal sac sign. Okay. Next one. What is the radiological investigation that we do for CSF leak? CSF leak can present as rhinorrhea, the CSF wala. The background history that you have is the patient who had past history of trauma, now having continuous rhinorrhea, right? So what is the radiological investigation? Very good, Dr. SG. That is CT or MR cysternography. It is a cysternography that we do. So what do we do is, in the subarachnoid space, by doing the lumbar puncture, we put the contrast in the subarachnoid space. We give the head low position to the patient. so that all the contrast goes in the subarachnoid space, including in the brain. It goes into the cisterns, the sulcal spaces. Then we give the prone position to the patient so that wherever is the leak, the site of leak, we get to see where the contrast is coming out from. So that is what is CT cisternography. Okay, that is what is CT cisternography, which is done for CSF leak. Next one, enlargement of which heart chamber causes esophageal indentation? Which heart chamber enlargement causes esophageal indentation? Very good. That is the left atrium. It can also cause the Ortner syndrome. The recurrent laryngeal nerve can be compressed. So if you remember the CT image, if this is the heart, right? If this is the heart, this is the sternum and this is the vertebra. So this chamber of the heart, which is just behind the sternum, the anterior most is the right ventricle. Right? ये midline है heart का. So whatever is to your left are basically the right-sided chambers of the heart of the patient. So right atrium, and left ventricle. So the anterior most chamber is the right ventricle, the posterior most chamber is the left atrium, and here behind that is where we have the esophagus located. So left atrium ke just पीछे we have the esophagus. When it gets enlarged, it will compress the esophagus. What else do we have here adjacent to the esophagus is the aorta, right? So remember, it is left atrial enlargement causing esophageal indentation. Obliteration of the retrosternal space is seen in enlargement of. So just now we said behind the sternum we have the right ventricle. So when it will enlarge, it will obliterate the space which is present in between the heart and the right ventricle. So that is RVH. Okay. That is RV. DKH, you would see the same image. Unfortunately, I don't have the MRI image here. Try to have a look at the Google images. Similar image is what you would see. So just behind the sternum would be the right ventricle. So adjacent to that would be the right atrium. Right ventricle ke opposite side mein on the left will be left ventricle, and in front of the vertebra would be the left atrium. Okay. So remember that RVH basically leads to obliteration of the retrosternal space. And when do you have RVH? When there is pulmonary arterial hypertension. Pulmonary arterial hypertension leads to RVH. Next one. So now tell me, where do you see the pruned tree appearance? In the lungs, and the pruned tree appearance in the biliary tree. Pruned tree appearance. What do you mean by pruned tree? A pruned tree is basically a tree whose peripheral branches have been cut off. So you don't see the peripheral branches. Very good, Dr. Shelby. That is pulmonary arterial hypertension. So what happens with pulmonary arterial hypertension? The pulmonary artery gets enlarged, and in the periphery of the lungs, you will see the vascularity is decreased. There is peripheral hypovascularity. The vessels undergo vasoconstriction. So remember, it is pulmonary arterial hypertension in the lungs, right, in the biliary tree. Very good, Campylobacter, Dr. Shelby. That is primary sclerosing cholangitis, which is associated with which condition? Which is associated with ulcerative colitis. Okay, associated with ulcerative colitis, right? And what appearance do you see with PSC? It is the beaded appearance. So you will see the biliary tree which has the beaded appearance. Okay. Is this clear with everyone? Next one. For lung cancer, investigation of choice, gold standard, investigation for staging, and what is MRI done for? Absolutely. The investigation of choice is contrast enhanced CT. One of the features that you might see is the lesion with the spiculated margins is what you would see, right? But the gold standard is, when you want to prove that this is a lung cancer only, we will have to do a biopsy. What biopsy do we do? CT guided biopsy is what we do. What is the investigation of choice for the staging? You want to see where all the cancer has spread. The most common investigation that we do is PET CT, right? The combination of PET and CT, which is an example of fusion or hybrid imaging, is what we do. And MRI is done for Pancoast tumor. Why MRI is done for Pancoast tumor? Because we want to see the brachial plexus invasion. The nerves, the soft tissues are better seen on MRI, right? So to look for that, we do the MRI in Pancoast tumor. And what is the clinical history that can be given in the Pancoast tumor? There is a lung apex lesion. The patient, because of the brachial plexus invasion, there is upper limb pain. Because of the sympathetic trunk involved, there can be horners which can be present, right? So horners, upper limb pain are the features that are generally associated with Pancoast. So remember, in that case, we do MRI. Next one, acute radiation syndrome. What is the sequence of involvement of the various organs? Is it the GIT first? Is it the CVS first? Is it the CNS first? Or is it the bone marrow first? First, at what dose do we generally get the acute radiation syndrome? Dose more than how much gives the acute radiation syndrome? Right, it's the bone marrow first. Very correct, Sam. It is dose more than 1 gray. Okay, it is dose more than 1 gray. 1 gray basically means how many rads? 100 rads. Okay, that means 100 rads. So, the most sensitive is the bone marrow. Then you have the involvement of the GIT. And then you have the involvement of the CVS and the CNS. CNS is the one, the neurons are the ones which are the most resistant to the radiation because they do not divide. The law of Bergoni, non-dividing cells are most resistant. Okay, so first will be the bone marrow suppression, then the GIT, and then the CVS and the CNS. That is what we need to know here. Next one, if the distance doubles, so the radiation intensity reaching a point becomes how much? Your recent NEET PG question as well. So there is this source of radiation. This person was standing at a distance of 1 meters. Now this person is standing at a distance of 2 meters. You are doubling the distance. Then how much will be the radiation as compared to the previous? Will it become half? Will it become 1/4? Will it become 1/8? Will it remain the same? What will happen? Absolutely right. It will become 1/4. Okay, remember it will become 1/4. Why will it become 1/4? Because the law that we have here is the inverse square law. Okay, the law that we have here is the inverse square law. Logically thinking, the further you go away from the source of radiation, the less radiation is what you would receive. And how much less? If you are doubling the distance, it is 1 upon 2 का square. यही अगर आप ट्रिपल करोगे, it is 1 upon 3 square, 1 by 9. So if you make it 3x distance, it will be 1 by 9. If you make it 4x distance, it will be 1 by 16. So the inverse, it is inverse to the square of the distance. Right, so remember it is 1 by 9 and 1 by 16 is what we have. Okay, so this is going to be 1/4, 1 by 2 square. Next one, where do you see the starry sky appearance in the brain? So in the brain you have multiple small calcified lesions scattered throughout the brain. Right, that is neurocysticercosis. Okay, that is neurocysticercosis. In the muscles, what kind of calcification does it give? The rice grain calcification in the muscles. Okay, the rice grain calcification in the muscles. In what condition do you see the starry sky appearance in the liver on ultrasound? In what condition do you see the starry sky appearance in liver on ultrasound? That means the liver becomes dark and you would see the portal radicals, the biliary radicals basically appearing white. This is seen in acute viral hepatitis. Okay, it is seen in acute viral hepatitis. The liver becomes edematous, so it appears dark on ultrasound and the portal radicals shine. And the starry sky appearance is also seen in Burkitt's lymphoma. It is also seen in PSGN on immunofluorescence. Okay. Next one. When do you call a small bowel loop dilated? If the diameter becomes how much more than how much, then it is called as dilated? Small bowel loop is called dilated if the diameter is more than 3 centimeters. So remember, we have the rule of 3, 6, 9. For the small bowel obstruction, more than 3 centimeters. For the large bowel obstruction, more than 6 centimeters. And for the cecum, it is 9 centimeters. Remember, cecum is the most distensible part. Okay, the most distensible part. So 9 centimeters for cecum. Next one. You have a patient of RTA who has low GCS but the CT scan is normal. What diagnosis do you think in that case? Typical history given. RTA patient, low GCS, CT scan is normal. The diagnosis is diffuse axonal injury. And what is the investigation of choice? It is MRI. Why? Because MRI with sequence, SWI sequence, susceptibility weighted imaging, is more sensitive to show the punctate hemorrhages in the MRI. Right? Otherwise, for head trauma, what is the investigation of choice? It is not contrast CT. But for diffuse axonal injury, it is MRI. Okay? Next one. Normal mammography is what, BI-RADS? Normal mammography is BI-RADS 0, 1, 2, 3, 4, 5. What is normal mammography? Yes. So remember, normal matlab none abnormality. None means 1. Okay, this is like GCS. When it is normal, it is 1. None is 1. So remember, it is BI-RADS 1. It is not BI-RADS 0. What do you mean by BI-RADS 0? Means inadequate study. We cannot comment on it. We need more views or we need some more investigation to comment. And what is BI-RADS 2 then? BI-RADS 2 is benign. Okay. How many total do we have in BI-RADS? The last one is the BI-RADS 6. What is BI-RADS 6? Which is already proven. Histopath proven breast cancer. It's an already known case of breast cancer. What is BI-RADS 5? Highly suspicious of breast cancer. So when you have microcalcification, that is basically BI-RADS 5. Architectural distortion, asymmetry, that is BI-RADS 5. So BI-RADS 4, BI-RADS 5, we need to do biopsy to prove that it's a cancer. Okay. Next one. What is the double bleb sign due to? Double bleb sign, if this is the gestational sac, you see 2 blebs in the gestational sac because of the yolk sac and the amnion. Okay, it's the yolk sac and the amnion which gives the double bleb sign. Double bubble sign in the X-ray abdomen is duodenal atresia. Right? So that is the double bubble sign in the abdominal X-ray. This is double bleb sign in ultrasound in a normal pregnancy. It is Sakshi, it is not the G sac and the yolk sac. It is the yolk sac and the amnion. Within the gestational sac, you see the 2 blebs. The outermost is the gestational sac. Okay. Next one. Which is the most radiosensitive and which is the most radioresistant cell cycle phase? The most radiosensitive is G2M phase and the most radioresistant is the S phase because this is where the cell is not dividing. Non-dividing cells are the most radioresistant. So remember, it is G2M and the S. Which is the most radiosensitive and the most radioresistant tissue? The tissue which is always dividing, that is the bone marrow, is the most radiosensitive. The tissue which is not dividing, that is the neurons, which is the most radioresistant. Right? So this is a question asked. The practical question asked is a patient receiving radiotherapy, which cells will be least affected? The neurons. Will the spermatogonia be affected? Yes, because they are dividing. Intestinal epithelium be affected? Yes, because it is divided. Okay. Which are the most radiosensitive and the most radioresistant tumors? The most radiosensitive tumors basically is Wens is the mnemonic. That is Wens tumor. That is Ewing's tumor. Then you have lymphoma. M stands for multiple myeloma. And we have seminoma. Okay, and we have seminoma. The most radioresistant tumors are morph. What does morph stand for? Here the M is for melanoma, not multiple myeloma. O is osteosarcoma. Right? R is RCC, P is pancreatic and H is HCC. Okay, H is HCC. Right. So remember, these are the most radiosensitive and these are the most radioresistant tumors. Next one. What is the nuclear scan that we do for Meckel's diverticulum? What scan do we do for Meckel's diverticulum? Technetium 99. So yes, that is the radioisotope used. But with technetium 99, what do you bind it to? Yes, Dr. Harika Vandana, absolutely right. You combine a technetium 99 M2 pertechnate. It is technetium 99 pertechnate scan. Why the pertechnate scan? Because it is taken up by the ectopic gastric tissue in the Meckel's. Right? Pertechnate is taken up by the normal stomach. It will also be taken up by the ectopic stomach. So basically, because of the ectopic stomach, we do the pertechnate scan. So that's why if the gastric tissue is absent, then we will get a false negative result in Meckel's. Next one. What is the nuclear scan which is done for the LV function? Sakshi, morph is melanoma, osteosarcoma, RCC, pancreas and HCC. Nuclear scan for the LV function, the left ventricle function. HIDA scan is for the biliary tree, the patency of the biliary tree to rule out biliary atresia. Yes, very good, Vandana. That is the Muga scan. Okay, that's the Muga scan, which is basically multiple gated acquisition. Okay, the Muga scan basically stands for multiple gated acquisition. So the nuclear scan for the LV function is the Muga scan. But if the question is for LV function, what is the most accurate for LV function? It is cardiac MRI. Okay, the most accurate is the cardiac MRI. Next one. Where do you get the bird beak sign on barium swallow and where do you get the bird beak sign on barium enema? Right. On barium swallow, that is the esophagus, where the esophagus is dilated and you get the narrowing in the lower part. That is achalasia cardia. And where do you get the bird beak on the barium enema? Where do you get the bird beak sign on barium enema? No. So when you're doing barium enema, the barium going up, and then at one point it becomes like a pointed. Right, it becomes pointed like this because beyond this point is the sigmoid volvulus. The volvulus does not allow it to go ahead. So very good, Sangam Gupta. So remember, it is the sigmoid volvulus. Okay, it is sigmoid volvulus that gives the bird beak sign, also called as the bird of prey sign. Okay, that's the bird of prey sign or the bird beak sign. Next one. What is the test done before giving IV contrast in CT? What is the test done before giving IV contrast in CT? Just give me a minute. I have lost the live chat. Just a minute. Yes, absolutely right. It is the KFT or the RFT. The most important test, the easiest test to be done is the serum creatinine levels. Okay, that is the serum creatinine levels because the CT contrast is the iodinated contrast which is nephrotoxic and we need to see the renal function before giving that. So, and what is the test done before the PET scan? Before the PET scan, basically we need to do the blood glucose levels because in the PET scan, we are looking at the FDG, the deoxyglucose uptake by the cells. If the blood glucose levels are high, it will interfere with the deoxyglucose uptake. So we will get false results. So before PET, it is blood glucose, and before the CT contrast, it is the KFT, that is serum creatinine. Okay. Next one. Where do you see the coffee bean sign on abdominal X-ray? So basically, DKH, we calculate the GFR from the serum creatinine. It should be more than 50. Right. The coffee bean sign on the abdominal X-ray is seen in sigmoid volvulus. Okay. It is seen in sigmoid volvulus, also called as the omega sign or the bent inner tube sign. Okay. Also called as the omega sign or the bent inner tube sign. Okay. Where do you see the boot-shaped heart? The boot-shaped heart basically is because of RVH in tetralogy of Fallot. So also called as core and sabo. Okay, remember the boot is the sabo, also called as core and sabo. RVH gives the boot-shaped heart. Where do you see the snowman heart, also called as figure of 8 heart? This is how the snowman is, also called as cottage loaf heart. So remember, snow falls from above, supra. So the snowman heart, snow is supracardiac TAPVC. The snowman heart is seen in supracardiac TAPVC, which is TAPVC type 1. Okay, TAPVC type 1. Where do we have egg on side or egg on string appearance? Yes. So majority of your cyanotic conditions, you have the plethora there, Suraj, except for TOF, tricuspid atrasia, and Epstein's, which have pulmonary oligemia. Egg on side, egg on string is TGA. Remember the association with maternal diabetes mellitus. But remember that not gestational diabetes mellitus does not cause anomalies because gestational comes later on, not in the first trimester. It is overt diabetes mellitus which has the cardiac anomalies. So the most common anomalies with maternal diabetes mellitus are the cardiac anomalies. Even in that, the most common is VSD. TGA is the most specific. Okay, TGA is the most specific. Next one, where do you have a box-shaped heart? Box-shaped heart is seen in Epstein's anomaly, which is the teratogenic side effect seen with lithium. Okay, that's the teratogenic side effect seen with lithium. What will be that liver lesion? If calcified liver lesion is given, even that is enough to make a diagnosis of hydatid cyst. Whenever you have a calcified liver lesion, think of hydatid cyst. That's the last stage, the healing stage in hydatid. And you have the water lily sign, that is the membrane floating, or you have the serpent sign, again the membrane floating, that is hydatid. Okay, that is hydatid. Next one, where do you see the football sign on abdominal X-ray? So on the abdominal X-ray, you see this, a ball of air. The football is of air. Air matlab pneumo. So remember that is pneumoperitoneum. Recent INI-CET exam question. Football sign is pneumoperitoneum. Okay. Next one. Where do you have inverted umbrella sign? Again, a recent INI-CET exam question. The inverted umbrella sign, which is basically representing the stricture in the terminal ileum along with the gaping of the IC valve. The widening of the IC valve, the gaping of the IC valve, absolutely right, that is seen in TB. Okay, that is seen in TB, the ileocecal tuberculosis. Next one, where do you have the string sign? Anywhere in radiology, the string sign is the narrowing, a long segment narrowing. So you have it in CHPS, you can get it in TB also, right? The stricture can give you that, but if you have to select one, go with CHPS. String sign of Cantor specifically is Cantor, K for K. Remember, it is Crohn's. So wherever we have this narrowing, that's the string sign. So specifically, if it is Cantor, then it is Crohn's. Where do you see the central stellate scar in the renal lesion and in the liver lesion? Which renal lesion gives the central stellate scar and which liver lesion gives the central stellate scar? Very good. Which renal lesion? It is oncocytoma, which can give the central stellate scar. And which liver lesion? It is FNH, focal nodular hyperplasia, or the fibrolamellar variant of HCC. And how do we differentiate the two? This shows a hotspot. FNH gives a hotspot on sulfur colloid scan. That is how we differentiate. This gives a cold spot. FNH gives a hotspot, right? Because it contains the Kupffer cells, the reticuloendothelial cells. That is why it shows a hotspot. Next one. If you have a patient who has lower limb blood pressure less than upper limb blood pressure, there is intermittent claudication and there is inferior rib notching on the chest x-ray, then what do you think of? It is coarctation of aorta. The collaterals formed in coarctation of aorta, the intercostal arteries prominent, they pulsate and give the notching on the inferior margin of the rib. So remember, that is coarctation of aorta, which is associated with Turner's syndrome. And if you have a hypertensive patient with acute chest pain and the unequal blood pressure in the upper limbs, not in the upper limb and the lower limb, then in that case you think of aortic dissection. Okay, then in that case you think of aortic dissection. The history can mention as a trauma patient also with mediastinal widening. So when you have a trauma patient with mediastinal widening, think of aortic dissection. The investigation of choice, if it's a stable patient, do CT angio. If it's an unstable patient, you can do transesophageal echocardiography. Okay. Next one. What is the investigation of choice for vestibular schwannoma? Yes, Suraj, Williams has supravalvular aortic stenosis. Investigation of choice for vestibular schwannoma, it's a small tumor, it's a nerve, soft tissue, so it is going to be MRI with contrast. Any mass, anywhere, we will do a contrast scan. Okay, so contrast enhanced MRI is what is going to be the investigation. Yes, it shows the ice cream cone appearance, and if it is bilateral, the diagnosis is NF2. What is the sensitive investigation for AVN? Avascular necrosis. Remember, the avascular necrosis first starts with bone marrow edema, right? The sclerosis, the collapse, those are the late stages. Okay? So that means if it is marrow, we will do MRI. Okay, it's going to be MRI. X-ray and CT show the late changes. If it is bilateral AVN, then we can do bone scan because multiple bones will be scanned in one scan. MRI is more sensitive than CT and X-ray. What is that bone tumor for which CT is the investigation of choice? CT is the investigation of choice for which bone tumor? So basically the bone tumor which is located on the cortex, which is a bone tumor located on the cortex, it has the cortical thickening and in the center it has a nidus. Cortical thickening with nidus. What is that bone tumor? Very good. That is osteoid osteoma. So remember OO. O is like the cortical thickening. Within that another O is the nidus. Because it is cortex based, that is why we do CT scan. Osteoid osteoma. RFA is the treatment for which bone tumor? Recent INI-CET question again. Same. With the radio frequency ablation, we can ablate the nidus of the osteoid osteoma. Right, so this is going to be osteoid osteoma, basically which has night pain relieved by aspirin. Okay, it has night pain relieved by aspirin. In which bone tumor do you have the fallen leaf sign? So you will have the lytic lesion in which you will see a bone fragment falling. That means it's a simple bone cyst. It's a unilocular bone cyst. So remember, fallen leaf sign is seen in simple bone cyst, also called as unicameral. Okay, Hemant, not in ABC because aneurysmal bone cyst is multiloculated. It will not allow the bone fragment to fall down. So that is going to be your simple bone cyst. All right. Next one. Soap bubble appearance. Tell me, where do you have the various soap bubble appearance? A bone tumor which occurs in the fused bone in the epiphysis. That means in a giant patient, it is giant cell tumor. Which other bone tumor looks similar to giant cell tumor? Occurs in the unfused bone in the metaphysis. Opposite of GCT is aneurysmal bone cyst. The age difference helps us differentiate the two. Where do you see the soap bubble appearance in MRI brain? Where do you see the soap bubble appearance in MRI brain? So in the basal ganglia, you would see those enlarged VR spaces. That is cryptococcosis. Okay, cryptococcosis, which is opportunistic infection. And where do you see the soap bubble in the abdominal X-ray? So in the abdominal X-ray, you would see some soap bubble appearance, the calcification there. Remember, it is meconium ileus. Okay, so the meconium mixed with air, that gives the soap bubble appearance. The meconium mixed with air. Very good, Dr. Harika. So remember, in the abdominal X-ray, it is meconium ileus. Next one, where are the various popcorn calcification? In the lung, the popcorn calcification, it is Hamara-Tomara popcorn. That means it is hamartoma. Okay, it is hamartoma. In the breast, it is fibroadenoma. In the pelvis, it is uterine fibroid. And in the bones, it is the chondroid tumors. It is the chondroid tumors like chondrosarcoma. Okay, so these are the various popcorn calcification. Next one, where do you have the tram track calcification in the brain? Following the gyri, you see the tram track calcification that is seen in Sturge-Weber syndrome. Okay, that is Sturge-Weber syndrome, where you will have the history of port wine stain. Remember, S for S. Sturge-Weber has stain, Sturge-Weber has seizures, Sturge-Weber is sporadic, right? It can come suddenly, it is sporadic. Where do you see the tram track sign in the CT chest? In the CT chest, the tram track appearance is the dilated bronchi, that is bronchiectasis. Okay, that is bronchiectasis. And in the kidney, where do you have the tram track appearance? That is MPGN. Okay, so you will have the tram track appearance in the MPGN. Next one. So what is the best investigation for bronchiectasis? What is the best investigation for bronchiectasis? It is not bronchoscopy, it is HRCT chest. It shows even the small bronchi, the peripheral bronchi very well. It is HRCT chest. Okay. Next one. Which is that adrenal lesion which has the light bulb appearance on T2 weighted MRI? Very good. S, absolutely right. That is pheochromocytoma. Okay, that is pheochromocytoma. It shows the light bulb appearance. It is hyper intense on T2 weighted MRI. And if you have a lung cancer patient who has an adrenal lesion with HU value of 2, what is that indicating? Is it adrenal metastasis? Lung cancer patient now has adrenal lesion. We have seen on the CT scan the HU value is 2. Is it adrenal metastasis? No. Remember that any adrenal lesion with HU value less than 10, straight away the diagnosis becomes adrenal adenoma, which is the most common incidentaloma, the incidentally identified lesion in the adrenal, right? Because this adrenal adenoma is lipid rich majority of the time. That is why it has less HU value. So remember that it is adrenal adenoma, it is not adrenal metastasis. Next one, in which brain tumor do you see dural tail sign? So you have a brain tumor and it extends along the dura like a tail. Remember, dura is meninges, so dural tail sign is seen in meningioma. Okay, it is seen in meningioma. Where do you see the drooping lily appearance on IVP? So on the IVP, you would see the kidney appearing like this. It is because of the duplex moiety, the upper moiety which is non-functioning, so it is not seen. It compresses on the lower moiety. So remember, droop is dupe. It is seen in duplication or the duplex moiety. Okay, it is seen in duplication or duplex. Complete duplication is where you see the drooping lily sign. Next one. If you have a silhouette sign with the loss of right heart border, then what lobar pathology it is? So you have the heart and you have a pathology which is obscuring the right heart border. So that is going to be right middle lobe. If it is obscuring the left heart border, you don't have the left middle lobe. So that is going to be lingula. Okay, that's going to be lingula. So right middle lobe and the lingula on the left. Where do you see the double density sign in the heart? Which condition in the heart gives rise to the double density sign? So you have the right atrium, you have the left atrium also coming towards the right side. So basically this is left atrial enlargement. Okay, this is left atrial enlargement where you would see the double density sign. It causes the splaying of the carina, it causes the straightening of the right heart border. On the lateral chest x-ray, it gives the walking man sign. All those are the signs there. And where do you see the double PCL sign? In MRI knee, the double posterior cruciate ligament. So if this is the MRI knee, in the posterior cruciate ligament, basically you would see the double PCL sign. Where do you see the double PCL sign, guys? So there is one PCL and similar to PCL, there is another structure that basically is the medial meniscus. It is the medial meniscus which has flipped and come in front of the PCL. So that is the bucket handle tear of medial meniscus. Bucket handle tear of medial meniscus, not the PCL. Okay, Jitain, it is the bucket handle tear of the medial meniscus that gives the double PCL sign. Where do you see the continuous diaphragm sign? This is the heart and you see the diaphragm continuous because in between the heart and the diaphragm there is the air. So that is pneumomediastinum, right? The air in the mediastinum surrounding the heart, that gives the continuous diaphragm sign which is seen in pneumomediastinum. Next one, what will be the barium minima sign in a child with red currant jelly stools? A child with red currant jelly stools, basically the diagnosis is intussusception, right? So the barium minima signs will be very good. That is the claw sign and the claw sign. And what is the other sign? That is the coiled spring sign. Okay, you see the coiled sign, the claw sign and the coiled spring sign. So when you do barium enema, the barium forms this claw. Okay, the barium forms this claw around the intussusceptum. Okay. What are the four C's? If I tell you that it's a child with a central lesion, that means a midline lesion in the brain, which has the cystic components and it has the calcification. So child, central, cystic, calcification. What is that lesion? Very good. The diagnosis is also C. That means it is craniopharyngioma. Okay, craniopharyngioma. It is basically suprasellar lesion, the remnant of the Redcase cleft, right? And that is the lesion here. It is craniopharyngioma. Okay, it is craniopharyngioma. Next one. And what lesion gives the central dot sign in the liver? In the liver, you have the lesions which give the central dot sign. So remember C for C, it is Caroli's disease. We are looking at the multiple C for C here. एक देखा craniopharyngioma का multiple C's. This is C for C. Central dot sign is the Caroli's disease. Where do you have the eccentric dot sign in the brain? So you have a cystic lesion with the eccentric dot. That eccentric dot basically represents the scolex of Tinea solium. It is NCC. The eccentric dot sign in the brain is seen in NCC. We are just talking about the dot. If it is eccentric target sign, that means within the lesion you are seeing another lesion, bada sa round. Then the target is T for T, then it is the toxoplasmosis. Okay, the eccentric target sign is toxoplasmosis. Right? When do you start the prophylaxis for toxoplasmosis? When the CD4 count is less than? When do you start the prophylaxis? CD4 count less than 100. And you start the prophylaxis with cotrimoxazole. Okay, cotrimoxazole. CD4 less than 100. Next one. Where do you see the target sign in abdomen? Target is the inner circle and the outer circle. We saw the eccentric target in the brain. Where is the target in the abdomen? Inner circle, outer circle. It is first seen in CHPS, the narrow pylorus and the thickened wall, and it is also seen in intersusception. Okay, and it is also seen in intersusception, the inner bowel and the outer bowel. That gives the target sign. It is also seen in inflammatory bowel disease, where you have the edema in the wall of the bowel. So it's also seen in inflammatory bowel disease. So these are the three conditions where you see the target sign in abdomen. Next one. How frequently is the TLD badge monitored? The TLD badge is monitored every 3 months. Okay, it is monitored every 3 months. Where do you see the hair on end skull? So you have the skull with the prominent trabeculae because of the increased hematopoiesis. Why do you have increased hematopoiesis? Because of the hemolytic anemia. So any hemolytic anemia, be it sickle cell anemia, be it thalassemia, G6PD, can give the hair on end, also called as crew cut appearance, right? It's a small hair, crew cut appearance. Next one, where do you see the cotton wool skull? Cotton wool is Paget's disease. Okay, cotton wool skull is Paget's. It has blastic phase, it has lytic phase, it has mixed phase, right? The cotton wool represents the white areas. So that is seen with Paget's. Okay. And where do you have the pepper pot skull? Pepper pot is the small, tiny lytic lesions in the skull. P for P, this is hyperparathyroidism, called as pepper pot skull or the salt and pepper skull. Okay, pepper pot or salt and pepper. Next one, what is the contrast used in esophageal perforation? What contrast is used in esophageal perforation? In any perforation, barium is contraindicated. So we use iodinated contrast. Okay, so we use iodinated contrast. Water soluble. Most safe is iohexol. If iohexol is not in the option, then go for gastrographin, which is also a iodinated contrast, but it is high osmolar. This is high osmolar and this is low osmolar. Okay. Next one, what is the isoosmolar iodinated contrast? Which is the isoosmolar iodinated contrast? Very good, Dr. Shelby. Absolutely right. That is iodixanol. Okay, this is iodixanol. The OL tells you that it is non-ionic. The di helps you to remember it is non-ionic dimer and it is isoosmolar. The brand name is Visipac. Okay, the brand name is Visipac. What is the iodine particle ratio of iohexol? Iohexol again is non-ionic and it's a non-ionic monomer. When it's a non-ionic, that means it does not ionize. So it gives one particle only. It does not ionize, so no two particles. Monomer means it gives 3 iodine. Monomer 3 iodine, dimer 6 iodine. So the iodine particle ratio is 3:1. Very good. That is 3:1. Next one, what will be the diagnosis here? A newborn with CHF with bulging anterior fontanelle and there is a bruit heard on auscultation. On ultrasound, there's a hypoechoic midline mass and the dilated lateral ventricles, that means it is hydrocephalus. What is the diagnosis here? What do you think is the diagnosis here? Yes, very good. Absolutely right. So the key word here, whenever you have a neonate with heart failure and with hydrocephalus, always the diagnosis is vein of Galen malformation. Okay, this is the vein of Galen malformation, which actually is the AV fistula, right? And it's not the vein of Galen. It is its precursor, the prosencephalic vein, basically, which is present and enlarged. right? And classically, you would see the sagittal image and you would see the dilated vein draining into the straight sinus. That is how the image would be. Okay, that is how the image would be. Arnold-Chiari, how would it present, Suraj? In Arnold-Chiari, it's a small posterior fossa, right? So what happens is there is peg-like tonsils of the cerebellum which are herniating down because of the small fossa, and it has associated syrinx. So many times it is asymptomatic, or because of the syrinx, it has the symptoms. That is in Arnold-Chiari type 1. Okay, that's in Arnold-Chiari type 1. All right, let's go to the next one. If you have a child with non-bilious vomiting and olive lump, what is the investigation of choice? So basically the diagnosis here is CHPS and the investigation of choice is ultrasound because it has no radiation. It helps us measure the thickness also of the muscle. So the criteria to make the diagnosis is measure the muscle wall thickness because it is hypertrophied. The thickness should be more than 4 millimeters. The length of the pylorus should be more than 16 millimeters. The pylorus is elongated and the muscle wall is thickened. Length more than 16, thickness more than 4. So remember 4 and 4 square. Okay. Next one. Bragg peak is seen with, is it seen with X-ray? Is it seen with gamma rays? Is it seen with protons? Where do you see the Bragg peak? So remember, BR is PR. The Bragg peak is seen with protons. What is the Bragg peak? As the protons go deep into the tissue, suddenly there is the peak in the radiation that they are giving at that site. So we can utilize this property basically to concentrate all the radiation on the tumor. So that is why protons are the one which can give pencil beam like targeted therapy, and that is why they are preferred if you have a child with brain tumor. If you have a tumor at very important site, aju baju mein there are a lot of important organs which you don't want to affect by radiation, then you use the proton beam for treatment. That is Bragg peak is seen with protons. Next one, tell me about the ventricles. Where do you see the boxcar ventricles, the racing car sign, and the bat wing appearance of the fourth ventricle? The boxcar ventricles are basically the dilated frontal horns because of the atrophy of the caudate. The caudate atrophy, remember C for C, caudate atrophy is seen in chorea. So that is Huntington's chorea. So remember hunter going for hunting in a boxcar, puts the animal in cage, that is the CAG repeat. The cage has 4 walls, so that means it is chromosome number 4. And this hunting is a dominant personality. It is autosomal dominant. Okay, it is autosomal dominant. Racing car sign, on the other hand, is the prominent posterior horns of the ventricles called as colpocephaly, which is seen in, remember, racing car, RAC. So the racing car sign is seen in AC is the agenesis of corpus callosum. It is seen in agenesis of corpus callosum. Bat wing appearance of fourth ventricle. So the fourth ventricle appearing like a bat wing. So that is basically the bat wing appearance of fourth ventricle is seen in Joubert syndrome, where you also have the molar tooth sign. Okay, that is the molar tooth sign where you have the elongated superior cerebellar peduncles. Okay, the elongated superior cerebellar peduncles, right? So that is where you have the bat wing appearance. All right. Okay, going on to the next one. Thank you, Campylobacter, for that. I think there's a sudden realization there. Figure of 8 appearance of the heart, figure of 8 appearance of the brain, and figure of 8 appearance in the pituitary. I think we are in the last lap of the discussion. So I think, yeah, few more slides to go. Figure of 8 heart, TAPVC. Very good. And where do you have figure of 8 in the brain? Figure of 8 of the heart we have already seen is supracardiac TAPVC. Okay, that is supracardiac TAPVC. Where is the figure of 8 appearance of the brain? So brain having figure of 8 appearance. Basically, it's a smooth brain without any gyri and sulci. It's just a superficial sylvian fissure that we see. So absence of gyri, absence of sulci, that is basically your lesencephaly. Okay, that is lesencephaly where we are seeing the figure of 8 appearance. Very good, Dr. Shelby. Right. And where do you have figure of 8? In the pituitary gland. In the pituitary, the tumor arising from the pituitary and then going out of the pituitary with the constriction. So it is coming from the pituitary and going out. So that is pituitary adenoma. Obviously, it's going to be macroadenoma because macro is large, more than 1 centimeters, micro is less than 1 centimeters. So pituitary macroadenoma is what gives the figure of 8 appearance. Okay. Not the micro, but the macroadenoma. Next one. What is the investigation of choice for stress fracture? Stress fracture again is a small minor fracture which might be missed on CT, but it definitely has the surrounding bone marrow edema. So again, because of the marrow, it is going to be MRI. For stress fracture, it is going to be MRI. What is the non-invasive investigation of choice to look for myocardial viability? For myocardial viability, or basically to identify whether this is hibernating myocardium, what is the investigation of choice? It is not echo, because in echo, the hibernating myocardium looks like a dead myocardium. It does not contract. The best is the PET scan. Okay, the best is the PET scan because the hibernating myocardium is the ischemic myocardium and it takes the FDG. Normal heart does not take the FDG, right? Because it does not use glucose, it uses fatty acids. But the hibernating myocardium will take up the FDG. So remember, this is PET. For the myocardial viability, it is the PET scan. Next one, where do you see the puff of smoke appearance on cerebral angiography? In cerebral angiography, so when you do the cerebral angiography, you see the contrast going out of the vessel like a puff of smoke. Absolutely right, it is Moya disease, right? Where you have a lot of collaterals which are formed because of the ICA stenosis. The brain forms a lot of collaterals. These collaterals are leaky. They have leaky endothelium and the contrast goes out like a puff of smoke. So that is where you see the puff of smoke on cerebral angiography. Where do you see the puff of smoke on fundus fluorescent angiography? In the fundus fluorescent angiography, the contrast going out is central serous retinopathy, right? Even there, the contrast is going out. So that is your ink blot or the puff of smoke appearance basically is what we get there. Central serous retinopathy. Next one. You have a patient of RTA with the injury. M mode of ultrasound shows the stratosphere sign. We have already seen stratosphere sign. The flat lines basically is pneumothorax. Okay, that is pneumothorax. So that is going to be pneumothorax. Next one. This is your previous AIMS exam question. Epidermoid cyst can be differentiated from arachnoid cyst in MRI by which sequence? Which sequence in MRI can differentiate epidermoid cyst from arachnoid cyst? It is diffusion weighted imaging and the second sequence is the flare. Why? Why DWI? Because the concept is both of them are cysts. So they contain like water-like substance, but epidermoid is like thick keratinous substance while arachnoid cyst contains the CSF. CSF is free-flowing substance, so it does not give restricted diffusion. Keratin is like thick substance, it gives restricted diffusion. So restricted diffusion present epidermoid, not present arachnoid. If you do a flare, in flare the water becomes black, so the CSF becomes black. So this will be suppressed on flare. This will be suppressed on flare, that means appear dark on flare. This will not be suppressed on flare because this is not CSF. So remember, these are the two sequences that we use to differentiate epidermoid cyst from arachnoid cyst, the DWI and the flare. Both of these will be T2 hyperintense and T1 hypointense, because that is how water looks like, right? When I say a cyst, that means it will be T2 bright and it will be T1 dark. So both of them will be T2 bright and T1 dark. Okay. Next one. Where do you see the Scotty dog sign? Where do you see the Scotty dog sign? I'm waiting for someone to get the right answer. No, it is not spondylolysis. It is not spondylolisthesis. So understand the concept that Scotty dog sign is seen in the normal spine. It is the normal oblique X-ray of the lumbar spine. It is the normal X-ray of the lumbar spine which shows that Scotty dog appearance basically. Okay, which shows that Scotty dog appearance. It is normal oblique X-ray. What is abnormal is the Scotty dog with a collar is abnormal. If there is a collar, that means then it is abnormal, and the collar represents the fracture of the pars interarticularis, that is spondylolysis. Fracture means the lysis. Now, after the fracture, the head of the dog becomes unstable and then it can become B-headed Scotty dog. B-headed Scotty dog is the slipped vertebra, that is spondylolisthesis. Okay, that is spondylolisthesis. So please remember that Scotty dog is basically normal, collar is spondylolysis, and B-headed is spondylolisthesis. Okay, B-headed is spondylolisthesis. Okay, so that is one point that I want all of you to understand the concept behind it. Next one, which radioisotopes are pure beta emitters? Remember PSY, Psychiatrica PSY, phosphorus 32, strontium and yttrium. These are pure beta emitters. Iodine 131 is not a pure beta emitter, even though the therapeutic effect is because of the beta rays, but along with the beta, it emits the gamma also. So it is beta plus gamma. It's not pure beta. Okay. Next one. Where do you see the signet ring sign in the chest and where do you see the signet ring sign in IVP? Signet ring sign in the chest, the dilated bronchus with the adjacent vessel. This is seen in bronchiectasis. Okay, so you have the dilated bronchus and the adjacent vessel, bronchiectasis. And where do you see the signet ring sign in IVP? So in the IVP, you see this contrast around the center which does not enhance. Rest everywhere, you have the contrast. In the center, there's the area which is not taking up the contrast. On IVP, we are talking about IVP in the kidney. Anyone, where do you see the signet ring sign in IVP? This is your previous AIMS exam question. Right. The central dead part, okay, the central dead part basically represents the papillary necrosis. Okay, it represents the papillary necrosis which is not enhancing. So multiple causes of papillary necrosis, like you have TB, sickle cell, diabetes, NSAIDs. So any cause of papillary necrosis can give this signet ring sign in the IVP. Okay. Next one, what is the half-life of iodine 123? Remember, 123 is used for diagnosis. It is used for radioactive iodine uptake scan. So that means it should have a less half-life. We are not using for treatment to have a long half-life. So remember the first and the last. That means 13 hours. Vandana, it is not 8 days. 8 days lamba half-life hai, which is for therapeutic one, which is iodine 131. 131 is therapeutic, 8 days. 123 is diagnostic, it is 13 hours. What is the half-life of technetium 99 F18? All of these used for diagnosis, they have the half-life in hours. Technetium 99 6 hours, F18 is around 2 hours, that is 110 minutes. Okay, so remember that diagnosis वालों का hours में है, treatment वालों का लंबा है. That is one trick that you can use to remember. Next one, and what condition gives a cold spot on the bone scan? Two important conditions that I want you to remember. Cold spot means that there is no newborn formation. Okay, there is no newborn formation. So remember, it is multiple myeloma. Okay, it is multiple myeloma because there's no newborn formation. We know that alkaline phosphatase levels are normal. And the other one is it fibrous dysplasia or is it fibrous cortical defect or is it both? Remember, it is FCD. It is a cortical defect, the absent bone there, right? So it is FCD, that is the fibrous cortical defect, not the fibrous dysplasia, not FD. It is fibrous cortical defect. What do you see in FD in the X-ray? It is the Shepherd-Crook deformity of the femur. Shepherd-Crook femur is what we see. Okay, so remember, it is multiple myeloma and FCD. AVN में Chaitanya also, there is the new bone which then forms again there, the surrounding one. So you see the hot spot there. Center में dead होगा, cold होगा, but आजू बाजू में hot होगा. Next one, what is the investigation of choice for posterior urethral valve? What is the investigation of choice for posterior urethral valve? Very good. Remember that even though it's a urethral pathology, but we do not do RGU here. It is the posterior urethra, that means adjacent to the bladder. So adjacent to the bladder, this is going to be MCU. It is not RGU. RGU is for the anterior pathologies. Again, if you do RGU, you will not see any resistance in the posterior urethral valve because the valve opens. If you push the contrast from here, the valve will open and the contrast will go up. The valve does not open when the contrast, the urine comes from above. And that's the reason it causes urinary obstruction, right? Because it's not opening when the urine is coming from up. In the MCU, the contrast is coming from upwards, and that is why then you would see the dilated posterior urethra that gives the keyhole appearance. Okay, that gives the keyhole appearance. So remember, MCU is the investigation of choice. MCU, also called as VCUG, widening cystourethrogram, is for V and V. That is for VUR and for PUV. So for the vesico-ureteric reflux and for the PUV, posterior urethral valve, we have the MCU, which is the investigation of choice. Right. So yes, that was all about the marathon of the 100 one-liners. We have completed the 100 one-liners. I think maybe one more, two, then 100 as well. I hope all of you have got a good rapid revision of all the important points in radiology. Apart from that, I've also taken the the dedicated image-based session for INI-CET in the previous session on the PrepLadder YouTube channel. So make sure you watch that as well, where we have discussed all the important areas as in INI-CET along with images. Right. So I'll share the PDF on my Telegram group, Dr. Harika, and everyone here. So thank you so much for joining in. I hope you have enjoyed it, and I'll see you again soon. Till then, goodbye, take care, and keep studying, keep revising, keep winning. And yes, thank you so much for all the love. Thank you.